The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our LymphCast show. Believe it or not, episode 66 tonight. Really glad that you're with us. We want to guide you to our website, LymphCastNetwork.com. We update that all the time, so come back early and often. If you have a question for anybody on the panel, you can write to us at hello@LymphCastNetwork.com. Dr. Eicher is here. Dr. Glavitsky is here. The gentleman who started the show, more about him in a little bit, Dr. John Chubak is here. Our special guest is here. And I don't know about you, people on the panel, also our listeners. I do have my coffee mug here. And we want to tell our people listening, you can buy us a coffee. How about that? Helps with the expenses here. If you enjoy the conversations on the LymphCast show, you can head over to buymeacoffee.com/LymphCast, and whatever you put in, we will gladly use to help with the expenses on the show. And with that, let me turn it over to physician, surgeon, and so much more from New Jersey, Dr. John A. Chubak. Hello, Dr. Chubak, and you'll bring in our special guest as well.
Hi, Paul. Yes, thank you very much. It's good to see everybody again. Tonight we have a great guest on the show, Dr. Mary Beth Hanley, who I have become familiar with through LinkedIn, which I've said many times on the show, I think is a great resource. And I've watched some of her posts and her work over the last couple of years and reached out to her to connect. And she was kind enough to accept our invitation to the show. Dr. Hanley is the CEO of Wound Management Experts of the Carolinas, and she's also a clinical professor at Edward Via College of Osteopathic Medicine at the Virginia Tech University, where she teaches medical students the basics of wound care and hyperbaric medicine. And she's also established a multidisciplinary limb salvage program in a hospital-based wound and hyperbaric medicine program. And so I thought, with all of the work that Dr. Hanley is doing in wounds, that she would be an excellent addition to tonight's show. And I look forward to getting to know her much better this evening. And with that, Dr. Mary Beth Hanley, welcome to the LymphCast podcast.
Thank you so much, John. It's great to be with you and this esteemed panel. I'm honored and humbled.
Well, it's a privilege to have you here. I think I'm going to kind of get the ball rolling with a very important question, and I think it's going to be one that Paul Reeves would like to know the answer to. Why are you a Red Sox fan?
Now, come on, you really know how to hurt a girl right out of the box.
This could be a fight, John, because they signed Alex Bregman to play third base. Make sure I saved that for we thought the Tigers were going to get him, and then Dr. Hanley stole them from the Tigers. That's how it came down.
If you really want to know something sad, the other team I root for is the Chicago Cubs. So I absolutely have some type of a loser fetish or something.
No, you're an optimist. That means
I am an eternal optimist. Yes, hope springs eternal every time spring training comes around.
Every specialist needs to be an optimist, you know?
Yes.
Sometimes
you
say this.
I tell my patients all the time, I look at the glass as half full. You know, it's never half empty, it's always half full.
Were you a Boston native?
I was born just outside Hartford, Connecticut, and grew up mostly there, and then most recently spent a lot of time in Rhode Island. So definitely had the Northeast influence. And growing up, I had a cousin who was like my brother, who was a rabid Red Sox fan. And so he taught me how to play baseball, how to hit, how to catch, how to do a box score. And so he instilled in me his passion for the Red Sox. My husband is a Yankees fan, so we have a mixed marriage.
Oh, boy.
That makes for a fiery Saturday afternoon.
Yes. Yes.
No, anyway, to go on a more serious note, why don't you tell us and our listeners how you became so passionate about wound care?
Oh, okay. So what I usually tell people when I'm asked that question, and it usually comes up when they find out that, my first residency was as an anesthesiologist, and I did my anesthesiology and critical care medicine residency at Johns Hopkins and loved it. And it was my passion, and I did it for 8 years until I got necrotizing fasciitis in my right arm and hand, which was my dominant arm, and lost quite a bit of the use of that arm. And so after going through a lot of surgeries and therapy and actually developing some lymphedema in my right arm and hand, I was not practicing medicine, and I was profoundly depressed, didn't know what I was going to do for the rest of my life. And a colleague of mine was running a family medicine program in Rhode Island, and she was a classmate from medical school. She called me up one day and she said, "Enough with the pity party. Your hand doesn't work, but your brain does." She said, "Come to Rhode Island, do 2 years of family medicine, get boarded, and get back into medicine." So in my early 40s with 3 young children, I packed up the house. My husband stayed in Connecticut. I went to Rhode Island with the kids, did a residency, would never have been able to do it without his support and encouragement, and got boarded in family medicine. At the end of my residency, they approached me and said, "We're starting a fellowship in hyperbaric medicine. Would you be interested?" And I said, "I don't know. What is it?" So they said, "Go over to the wound center, spend some time, see if you like it, and let us know." So I went over to the wound center, spent some time, got to know what hyperbarics was, got to see wound care, and I realized, hey, this is it. This is my calling. This is, when you get lemons, you make lemonade. Well, wound care and hyperbaric medicine became my lemonade. I get all of the physics and gas laws and all the things I love with hyperbarics, and the wound care was just the frosting on the cupcake. I fell in love with that. I realized I still had a lot of good I could do, that these patients need an advocate. There is no telethon for wound care patients or lymphedema patients. They're orphan diseases. And so we need, people who will advocate for them and stand up for them and continually learn and better the treatment and the therapies that we have for them. So that's a very long answer to your question.
Well, it's a fascinating story, and we hear so many of these stories of colleagues and patients and so forth reinventing themselves. I certainly did as a cardiac surgeon, then finding venous disease and office-based treatment in an ambulatory setting, and I just find it very inspiring. Monica, what are your thoughts?
Well, I think it's wonderful that through the all steps in your life, some people are finding their calling, and especially for the wound care patients and lymphedema patients, because I think that indeed this is a little bit specific situation, because not only they are sick and they are suffering, but this is not a very appealing a pathology, like somebody has cardiac disease and everybody is coming and visiting, having the totally different attitude. And people with the extensive wounds are having a very particular situation. And if they have the motivated physician, that's wonderful. But my question is also, especially in the situation of the United States now, with all the changes that we see, do you think that we have enough of support for those patients from the healthcare structure? What is your opinion?
I would say unequivocally no. I mean, the lymphedema, the recent act that was passed, the Lymphedema Reduction Act, is a good step in the right direction. It allows us now to be able to get modalities, treatment modalities, more easily for patients, to get them the compression hose, get them the, the Velcro compression sleeves, whatever. The simple fact of the matter is that a lot of, at least where I practice, most of my patients are clinging tenaciously to the bottom rungs of the socioeconomic ladder. So for me to go in and say, oh, you've got to go buy 3 pair of stockings that are going to be $100 each, or get the intermittent pneumatic compression pumps that are over $1,000. It's just, it's the choice between that and their prescription or food. So realistically, I think the act is helpful, but I think we still have a long way to go. And just as you said, Monica, I couldn't agree more. When I spoke recently in Iceland at a conference, and I likened what we do in wound care to, we are the firefighters of healthcare. When you look at a firefighter, they run into a burning building that everybody else runs away from. We, as wound care and lymphedema specialists and vascular medicine and hyperbarics, we see these patients with these horrific wounds, these challenging diagnoses, and everybody else in medicine runs away. They don't want to touch them. They don't want to deal with the complex problems. We're the ones who run in and say, yeah, we can treat this wound. We can fix your edema. So it's kind of a interesting analogy that I thought of one night in the middle of the night when I couldn't sleep. But I think we have a long way to go. And I think we need more and more advocates who are vocal and outspoken in the media, in podcasts, to the government, to politicians, that these patients are out there. There's more and more of them. The number of chronic wounds is predicted to rise significantly even by 2030 in this country, with the aging population and the diabetes epidemic. There's no shortage of patients with wounds and lymphedema, secondary lymphedema, lipedema, phlebolymphedema. So the challenge is getting people into the field who are trained well and understand the pathophysiology, understand the diagnoses, and then understand how to treat them appropriately.
Now, I have a couple of follow-ups on that, if you don't mind, and I'll bring Monica back into it. Monica has been involved, and Monica, you'll correct me if I'm wrong. I believe it's called the Olmsted County, Minnesota study that has been following the incidence and prevalence of venous leg ulcer over the last 50 years or so. So to follow up on what you were saying, Dr. Hanley, it seems that for a multitude of reasons, the incidence just of venous leg ulcer itself is on the massive rise. Correct, Monica?
So actually, I will add a little bit more precision.
Please.
Actually, the Olmsted County with Mayo Clinic is a wonderful example, because this is a small county which has the healthcare all done by Mayo Clinic and also Olmsted County Hospital. And in this small town, you have the situation that everybody was having the very well documented the medical files. And that gave the opportunity to the epidemiological studies and studies on people that were really stable in that little town through many, many years on many topics, because it was not only for ulcers, but you have a very famous study for obesity, for thrombosis, etc., etc. I had the opportunity to study ulcers And indeed, it was kind of surprising because really the level of the care that these patients at Mayo Clinic and Olmsted County healthcare are having, I was suspecting that during the last 10, 15 years, we will see the tendency to have the smaller incidents and a better situation for this patient. Not at all. Actually, the incidence is growing. And this certainly because of the aging of the population. And I think that's one of the explanation. Another explanation I would say that might be despite a good healthcare that you may have over there, we are all in the United States facing the epidemic of obesity and all the pathologies related to it, such as diabetes and others. So maybe that's a very complex situation in which really we are seeing more and more ulcers, not only venous but diabetic ulcers and others. I don't know what is your thought, but
I have one other follow-up for Mary. Thank you, Monica. That's fascinating. So it's really Olmsted. I was not aware of this. That it's sort of like a sister study of sorts to Framingham, it sounds like. Some thing.
Similar situation without the properly setting, but this is just because everybody is treated within the Mayo Clinic or Olmsted County, and you can find all the information. And Mayo actually were the very first to implement really a very good system of the documentation for the patients. They had the Dr. Plummer, who was the very first to really put the order and systematic setting for it. So now, for example, like since many, many years, you have all informatic system, so it's even easier. And it's fascinating what you can get from it, because it's all the information is there.
Very, very powerful. Mary Beth, let me ask you one more question before we move on to Emily and Dr. Eicher. You mentioned the Lymphedema Treatment Act, and we all have had such high hopes for it, but I was always a little bit skeptical, only because I suppose, a bit of a pessimist by nature. But are you finding that your patients are able to, I don't want to use the word easily, but let's say easily, get their compression garments paid for through this program and through the government and through insurance?
So far, John, I would say I've been pretty pleased. The one caveat I would put out there for clinicians is that there is very detailed verbiage that has to go into your documentation. And once you get that, and you can make it into, a smart phrase or something that you store, and you can just kind of, I hate to use the term cut and paste, but you can take that verbiage and put it into the note and tailor it to that particular patient. And as long as the payer sees that verbiage, they've paid for the garments that I order. So far, so good.
Yeah,
right. It's the magic words and a lot of crossed fingers.
Mm-hmm. Well, that's good. That's good to know that at least when done properly, it goes ahead. It goes through. Dr. Eicher, please.
I just want to add on. It's more paperwork for the physicians, and how it works here I'm in Santa Monica. We have to put that verbiage into a specific documentation that goes to a vendor. Now, the patient has to go to the vendor. That has to be measured then, and it's a lot of patients say, hell, I don't want to say that. Hell with that. I will just pay and get this because I am wasting time going twice, being measured, and then it's much more paperwork from physician and more time consuming from the patient. So it's not as smooth as it sounded on the documentation for us, that, okay, we have this, then Medicare will pay for this one. And then Medicare pays only a portion. So it's not the full reimbursement.
Right. The one thing I found with the measurements, I agree, Dr. Eicher, absolutely. What we used to be able to do was we could measure the patient and, send the measurements and get the garment or whatever. Now you're absolutely correct. Now they have to go to the vendor, get measured by the vendor. Then the vendor has to send me the measurements. They won't accept my measurements. It has to come from the purveyor. And then I have to put the measurements in my note as well as that verbiage. So it's not easy, but anything that has to do with the government and getting paid is never easy.
And the only thing is, I have been doing it for over 30 years now. And I look at the patient and I tell you, you are size 2, you are size 3. And then if you have a new vendor who is now learning how to measure and she's putting someone to size smaller, then the patient is complaining. So there are a lot of ins and outs, but I would say it works 50-50 because patients do get tired of this and they buy on their own from www.
Amazon.
Not Amazon, Lymphedema products.
Right.
Yeah. So it's challenging, but back to you, compliments that you are doing this very tedious work and it's not really well recognized. And many times I see patients and even when I have a patient now who is covered in home health. And when he came and he was bandaged and with the wounds and so on, I couldn't believe. Then I found out that LVN, instead of physical therapist, is bandaging his legs. And she was never trained how to bandage. So it's really a challenging situation. But compliments for your incredible work that you are doing. And maybe you can tell us a little bit more how you approach these open wounds and what do you use and how much time do you spend, what kind of products do you use for these patients and how you get them better.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
And I loved hearing what Monica had to say about the Olmsted project. And one observation that I've had recently, and maybe you see this too, John, in your practice, is I'm seeing venous ulcers and venous disease in younger patients. I'm seeing it in, 30s, 40s, 50s. It used to be, pretty much the elderly, 70s, 80s, but I'm seeing it in younger and younger patients. And I think, part of it, especially where I am in Charleston, this is the diabetes, this is the buckle of the diabetes belt. And we also have a multi-generational problem with obesity. I mean, the Southern diet is not a healthy, low-fat, low-carb diet. So we're seeing these wounds in younger folks, folks who are dealing with obesity and diabetes. The first thing I do, and I try to teach this to my students is, when you walk in the room, don't look at the wound first, look at the patient, look the patient in the eye, shake the patient's hand, because we're here to fix the whole patient, not the hole in the patient. And so a lot of these patients have been shunted from one doc to another doc, or worse, they've stayed at home because they're embarrassed. The wound may have an odor. They might have drainage. So they've alienated themselves. So just the fact that they've come and they've sought treatment, warrants being treated respectfully. And so the first thing you do at the first visit, you got to make the diagnosis. Is it a venous ulcer? Is it an arterial ulcer? Is it a diabetic ulcer? Is it pyoderma gangrenosum? So I do a lot of first visit. I do a lot of testing. Almost everybody's going to get vascular studies. They're going to get a venous duplex. They're going to get an arterial, an ABI. For the diabetics, I'm looking for an A1C. I'm looking at prealbumin. Nutrition is unbelievably abysmal in patients who are upright and walking and look like they would not have, a prealbumin of 10. But I see it regularly. Protein is expensive. People don't buy a lot of protein and eat a lot of protein. So getting the correct diagnosis for what you're treating is probably the most important thing. I teach my students never pick up a sharp instrument until you know the patient has pulses. And I see time and again patients come to me who've had a bunion repaired or some other type of surgery on their foot. And when I go to check, and the wound hasn't healed, and when I go to check for a pulse, there's no pedal pulse. So surgery's been performed on a pulseless foot. So the first thing you want to do before you pick up anything sharp is you want to check for pulses. You want to use your Doppler if you can't feel it palpably, and document all of that. And then if I determine that, this is a venous ulcer that we're dealing with, then it's going to involve, debridement. I'm a very strong advocate of meticulous debridement and preparing the wound bed for whatever treatment you're going to do. The big thing now in wound care, the hot, sexy thing is all the cellular and tissue replacements and skin substitutes. And I cannot tell you how many times I have patients come into me who've had 8, 9, 10 skin substitutes placed on a filthy wound. That the wound was never debrided. Someone's just been throwing skin subs on it. So that's a big problem in the wound care profession, that many people who are doing wound care are not trained in basic surgical techniques of how to debride a wound properly. And once you get the wound bed clean and you control infection, you control drainage, the mainstay, I tell patients all the time, the mainstay of venous therapy is compression. Compression, compression, compression. Lifelong compression. Not a week, not a month, not a year, forever, every single day of your life. And they still come back to me 2 or 3 months later because they didn't wear their compression and they have a new wound or the same wound is reopened. But, that's life, and we're all human. We all fall off the wagon now and then. And I just say, okay, let's get you back on target. But that's kind of where we start. I use a lot, as far as dressings and products, I use a lot of collagen products, a couple of the ORC collagens. I also like, there's a copper foam on the market, which is a foam that's impregnated with copper. Copper's antibacterial. It helps to keep the microbiome on the wound clean. I use products that help to decrease biofilm. Biofilm is a huge problem in these chronic wounds. And again, debridement is the key to managing biofilm and preventing it from taking over a wound. Compression therapy, compression wraps. I have great nurses and a team who work with me, and they can wrap a leg faster than you can blink an eye sometimes. And it's amazing the results you can see with just a couple weeks of good, consistent compression therapy, elevation, and education. The word doctor means teacher. And I think that sadly, the way the healthcare system is set up now, where you have 15 minutes to do a visit, the thing that gets cut is the education piece. And that's really the most important part of the visit. And it's great to give the patients a handout at the end of the visit or to tell them to go to a website, but it's a teachable moment when you have that patient in your clinic sitting there in your treatment chair and you're looking at them eye to eye. If you say, if you just lost 10 pounds, your blood sugar would be better, your blood pressure would be better, this wound would probably heal better. Sometimes you get such a short time to make that impact. And that's just a sad fact of the current state of our healthcare system. But I still think if you can just give a couple of teaching points at every visit, I tell patients all the time, knowledge is power. The more you know about your diagnosis, the more you know about your disease, the better you're going to try to self-manage. And I tell them too, I'm the coach. I'm the coach on the sidelines. So I'll call a play, but you're out on the field. And if you decide to call an audible and not do what I say, then that's up to you. But I'll still be here on the sideline. So if you decide, yeah, maybe she did know what she was talking about, I'll still be here.
That's wonderful. That's you are
At Vita Support MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness.
It's beautiful.
The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before.
We all
Support
know
your
that,
body with the flavonoids it needs to fight inflammation and oxidation.
Active drugs
Unlike other products in the marketplace, Vita Support MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body.
People
At
like
Vita
John
Support
and
MD,
others,
we are passionate about making your
this
good
option
health
open to the
our
to the
life's
patient.
work.
So the question is, do you have experience with?
I don't have a lot of experience. I'm going to be perfectly honest, and it's frustrated me for many years because really the only thing I could offer to my chronic venous insufficiency patients was pentoxifillin, very old drug, developed for claudication, very safe drug. And for some patients who I put them on it for venous ulcers, it does help. I wouldn't say that it helps the majority, but some it does. But I would be very open to learning more about your work and John's work, because I think that one thing that we get very little education on as physicians, at least I did in my medical training and in medical school, is nutrition and how, substances in foods and biochemicals can really alter so many things in a favorable way in the body. And I think that that's definitely an area that I'm going to work to learn more about and hopefully be able to offer it to my patients. Because one thing that I say to them all the time is, there's no magic pill to fix this disease. You've got chronic venous insufficiency. The chronic means it's forever, and I can't just give you a pill and take it away. And, we in America, we want a pill. We want a pill we can take and just make it go away. And there isn't one. But if we could, have something that is going to speed the healing process and decrease their morbidity and get them back to work, get them back to function, to taking care of their grandkids or taking a walk, the things they want to do, then I think that would be extraordinarily valuable.
It is. Actually, there is no miracle, because that chronic disease will stay chronic disease. But that is the treatment that helps give you an extra help in a patient with venous disease. So the MPFF, or micronized purified flavonoid fraction, as other venoactive drugs, are accepted all over the world as drug. Not in the United States. In the United States, they are commercialized as a nutritional supplement, but they give. So to give you the example, we had the extensive studies in venous leg ulcers, and with a meta-analysis that was done on those randomized controlled trials, what was found that actually you have 30% better healing in patient treated by MPFF, 1 month shorter time to heal. And indeed, as for those patients, you have the underlying venous disease, the more you treat, the better results you will have in the future. We don't have the data on the prevention of the recurrences, which is kind of missing. But I'm personally, knowing the effect of the treatment, I wouldn't be surprised if you buy this treatment, you can decrease the recurrences of the venous ulcers. So highly recommended, and you really should give a try with your patients. Now, I have another question, which is not on the compression or drug treatment, but on the exercise, because this is another issue with those patients with the very often obesity, with very often limited range of motion of the leg. So they are not moving spontaneously a lot. What is your advice for those patients as far as exercise?
So what I'm a huge proponent of walking. And there's a vascular surgeon by the name of Chris Attinger who practices at Georgetown. And he actually comes right out and says, when you're not walking, you're dying. And when you think about it, we put patients, even a healthy patient, in a bed for a few days, and the muscle mass starts to go away. So exercise is critical. And I explain to patients especially with venous insufficiency, it's the calf muscle pump. You've got to use that pump. And for lymphedema, you've got to contract those muscles. That's what's going to mobilize the fluid and get those lymphatics pumping. So, I tell them, and I have a lot of patients who live in a recliner chair. 24/7, they're in that recliner chair. They sit in it all day and they sleep in it at night. And I'm on a mission to eradicate that. But I tell them, every time you're sitting in that chair and you're watching television, when a commercial comes on, you get up and you walk around the house. You do a lap around the kitchen. Start small. Like you said, some of these patients are morbidly obese. Just to walk from the chair to the bathroom is an aerobic event for some of these patients. And I'm not being flip. I'm being very honest. So I tell them, start little, set small goals, but then, the next thing, you're going to walk to the mailbox and you're going to walk down the driveway and get the mail. Walking, we know for PAD, for our claudicants, the best thing we can tell them to do is walk. I really firmly believe it's the same thing for our venous insufficiency patients. They're not going to run a marathon. You got to have realistic expectations. But if you can just get them to take a walk at night with their spouse or with their grandchild or with their dog, it will have a huge positive impact, not just physically, but mentally. We know exercise releases endorphins and does all kinds of wonderful stuff. So part of what we have to do is we have to be motivators and coaches. But it's a huge part of the treatment.
Yeah, Mary Beth, I'm gonna jump in. You're just I could tell you already before we're done, you're a new favorite of the LymphCast podcast. You're such an absolutely fabulous and knowledgeable physician, and also obviously your students are very, very, very lucky to have you in their corner.
Oh, thank you.
Because you're a great educator, and I mean that from the bottom of my heart. We have a lot of guests on this show with varying degrees of knowledge, but you have a great wealth of knowledge, understanding, and an ability to communicate that knowledge. And I just want to point out a few things that I take copious notes. I'm one of these kind of learners. But one of the things I want to sort of double down on that you said, a few of my favorite expressions. I love that you said, treat the whole patient, not just the hole in the patient. One of the things my professor taught me a long time ago is that unfortunately too many Americans are overfed and undernourished. And so nourishment is so important, and dietary supplementation, not just with micronized purified flavonoid fraction, but with, as you said, protein supplementation in the diet where you can, and all of those other important nutrients, vitamins, and minerals that are so important, A, D, E, K, zinc, for wound healing. So that piece, I absolutely agree and congratulate you on. And now this piece, I recently did a post on Instagram and LinkedIn and TikTok where my kind of eye-catching title was "Sitting is the New Smoking." So not only is the ambulation and walking so essential for the wound healing and the calf muscle pump and the effect that has on venous circulation and lymphatic circulation and on arterial circulation, how important walking is in the microvasculature and so forth. But we also know that this prolonged sitting has been shown to increase risk of diabetes, increase risk of cardiovascular disease, and definitely increase risk of early death. So you're doing your patients such a wonderful, wonderful service by educating them that way, doctor, as you said, Dr. Educator, another beautiful point you brought out. And Dr. Barry Franklin, who's a PhD physiologist who just retired from Beaumont Hospital up in Detroit in Hall's neck of the woods, has written 700 peer-reviewed articles, many of them on the incredible overall health benefits of simple walking. And I'll just reiterate one point that you made, Mary Beth, which was so key, and I want listeners, doctors, and patients to hear what I'm going to say. The patient who can walk 2 miles a day, who increases to 3 miles a day, does very, very little to improve their health, longevity, etc. But the patient who is truly sedentary and sitting in that lazy boy recliner all day and sleeping in that lazy boy recliner, if they go from no walking to 5 minutes of walking a day, they have a massive, massive effect on their survival and overall health. So a little bit of activity in someone who's completely inactive is incredibly important. So for the patient out there who's inactive, don't think that just a few minutes of walking, as Mary Beth, as Dr. Hanley says, around the kitchen, down and back in the hallway in your home, to the mailbox and back. If you think that it's not doing anything, science and research and many studies have proven you wrong. It's doing a lot for your health and your wellness. So I just want to point out all of those things. And the other one more term I'm going to throw out there when it comes to all of the good work you're doing in wound care, bringing circulation, debridement, compression, and that Monica brought up, the micronized purified flavonoid fraction, etc. We have to always remember oxidative stress, free radicals, and this antioxidant effect that all of these therapies, when put together, are really working to reverse. And our dear friend Mark Moline up at the Mayo Clinic, he's not here, so we have to say the magic word for him: the glycocalyx. That's right. It's all about protecting the glycocalyx and sealing the endothelium and so forth. So I just kind of wanted to just congratulate what a beautiful summation you made and what a great teacher you are.
At VitaSupport MD, We believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
I wanted to point out very briefly, before the patients, if they cannot get up, there is a new thing of the chair exercises. So you can just do little stretches and little strengthening and rotation while the patient is in the chair. And once they get a little bit stronger, then they can stand up. One point. Another point is in terms of nutrition. We got together and wrote a book on Lymphedema nutrition guide. And you can get that book on Amazon, and it's a very good book. It tells you even some recipes. Most of the patients, especially the sedentary ones, and compliments that you see a patient as a whole instead of just looking at one ulcer or two ulcers and so on. But every patient who comes for consultation, I also point out nutritional aspect. And the most important thing is get rid of sugar. And a lot of these patients who are on the chair, sleeping 24/7, they said, "Oh my gosh, but that's what I like the most," of course. So get rid of sugar, get rid of gluten and dairy products too. So all is in that book, Lymphedema Lipedema Nutrition Guide, and it's very beneficial for patients.
I'm going to order that. Here we joke here in the South, the staples of our diet are, Mountain Dew and a Debbie cake for breakfast. So I work very hard to overcome some of the traditional dietary. Everybody loves biscuits and gravy, and I tell people I'm not going to tell you can never have that again, because you're going to go out and order a big plate every night that you possibly can. But I just try to tell people you could have anything you want as long as you do it in moderation. If we can just start with that, it's little baby steps. Get rid of the soda. Watch your carbs. Just have one serving of carbs a day. I tell the students all the time, sometimes you just got to meet people where they're at, and not just try to bulldoze through. And it's just those little steps. That's how, an olive tree grows from a little tiny seed into a huge tree. You just start little by little.
Beautifully said.
Wonderful. So, and a question also, do you think that you have the disparities in access to the wound care and hyperbaric oxygen treatment? What is your opinion about this point?
Well, I think that a lot depends geographically where you are. I can only, from my experience where I am, there are definitely disparities. And the rural counties, the rural population, there was an article written by one of the major newspapers in South Carolina a few years back, and it profiled one county right near Columbia, which is the capital, which had the highest rate of major amputations in the country. One county in South Carolina. It's predominantly African American, it's rural, And these patients were just not getting preventive care, and they were presenting with gangrene, and it was just amputation. So there definitely still are disparities in this country, and you know, in my state. As far as hyperbarics, what I see is that there's definitely there's fewer and fewer 24/7 hyperbaric centers now. Most of them are just our 9-to-5 programs that aren't taking call and aren't doing emergencies. So that's limiting access all across the country for emergency hyperbarics. And what's a typical emergency? Carbon monoxide poisoning, cyanide poisoning from house fires. So people are having to be airlifted, you know, sometimes hours from where they live to be treated emergently. So that's just a problem all across the country. But as far as wound care treatment, lymphedema treatment, the system I work for in Charleston, Roper St. Francis, we recently purchased a big camper RV and turned it into a mobile clinic. And we're going out into the rural counties and trying to provide preventive care, primary care. I'm trying to get on board to go out and do some wound care because, you know, there are people who have transportation challenges. You know, they don't have a car. They don't have anybody who can drive them. They can't get to where they need to get in order to get care. So it can still be pretty amazing in this country where, you know, we think we're so far ahead of the rest of the world, but there's still a lot of third world medicine in this country.
Amazing.
Now, I think a lot of us are starting to wake up and disabuse ourselves of that myth as we interact more, and Monica and Emily would be great champions of what I'm saying, as we interact more, especially with our European colleagues, and in many cases, some of our Asian and South American colleagues as well. I mean, there's a lot of tremendous knowledge out there, and in many ways, although we always like to think of ourselves as the best, it isn't always true, and in some cases, we're way behind. I mean, look at MPFF. I mean, we were at least 30 years behind them bringing that to the States as a dietary supplement, and maybe because Big Pharma couldn't find a way to make it a drug. But nevertheless, there are even the field that I'm in, the treatment of chronic venous disease and chronic venous insufficiency. When I first trained 20 years ago, we were, I would say, at least 20 years behind, right, Monica, the Europeans?
Easy because this is a pathology which is very well recognized and treated, and with the subspecialty diploma that you have in phlebology that existed in Europe since 2000. So really, it's not even comparable. It doesn't.
So that's the point of, and that's, you know, we live in a magical time. We live in a golden age where we have access to programs like this, the LymphCast podcast that I'm very proud to have started with my wife, Diane, and with Paul and Emily and Monica. We live in a golden age in the sense that this technology now allows folks like ourselves to decide on our own that we want to create a program, a platform, and share our knowledge and invite knowledgeable guests like you, Dr. Hanley. We don't need permission anymore of, let's say, a major television network to decide whether or not our program is valuable or worth putting on the air, or the same with writing a book, the same with having a podcast or a radio show, the same with so many things that this technology now. Look at how many artists are putting their art out on the internet for people to see and appreciate and love and buy and collect. Whereas only 10 years ago, if you weren't accepted by some gallerist in a gallery, you couldn't show your work. So I think that it's just magical that any one of us can now have their own television program, radio program, publish a book on demand without having to print 1,000 copies. It's a magical time. And I think with all of its drawbacks that we all are aware of and complain about with social media and so forth, I cannot tell you the number of fabulous relationships that I've made just through LinkedIn. And today's interview is an example of that. I'm very active on there, and I have no regrets because we have made so many collegial connections. In fact, just today I was invited to work on a project with a physician from England who happens to know Monica and her husband Peter very well. And if it hadn't been for LinkedIn, I wouldn't know Mary Beth Hanley. I wouldn't know this other physician from England. And so I think it's important once in a while to step back and be positive about the technology and social media. When it's being used for good purposes in a good way, it's an incredibly, incredibly powerful tool. And then we can get our knowledge out to the people, to the patients, and to other physicians and therapists and our colleagues, nurses, APPs, wound care specialists, etc. And I'm just blown away. It's like living in a time of science fiction, quite frankly.
It is amazing.
Yeah, well, certainly, but I think that we are spoiled because, of course, we almost forget the time that it wasn't that easy. It wasn't easy even to call somebody because there was no cell phone, and fortunately the world is progressing with the sometimes the not pleasant side of the technologies, and sometimes a great side as our rencontre today. That's wonderful.
Yeah, I want to mention one more thing before we wrap up that Mary Beth had touched on, and it was something. It's not new to me anymore, but it came to me long after I finished my cardiovascular training, and she was talking about, and I harp on the value of the physical examination. I love the fact that she's teaching her students to check pulses, pedal pulses, etc. But Mary Beth, one thing you might want to touch on, because we know so much of this, of course, diabetic foot and diabetic ulcer, arterial ulcer, has always been known to be a microcirculatory problem. But now we know, of course, venous leg ulcer is also a microcirculatory problem. And not just arterial, but arterial, venous, and lymphatic. The whole circulation is involved at the microcirculatory level. Talk to us, please, if you would, about the importance of not just ankle brachial index as an examination, but ankle toe index as an examination today in the patient who may have a present pedal pulse.
Right. And one caveat, John, that I do, I do try to teach the students when they rotate with me a little bit about the non-invasive testing that we do, and they'll get so excited when they find an abnormal, ABI on a patient, and I say, well, you know what? Well, that patient is diabetic. What do you think? Maybe how do you think the diabetes is going to affect that test? Do you think it's going to be 100% accurate? Can we put our money on that? And the TBI, oftentimes the toe brachial index is more of a money shot, because sometimes I'll look at that and I'll say, well, you know what? The ABI was non-compressible, or it looks like it could be in the realm of normal, but the TBI is not. So then you got to start thinking, well, wait a minute, is there more proximal disease? Is this not just disease, below the bifurcation at the knee? Is there something going on higher up? So I'm very fortunate in that I work with wonderful vascular surgeons. They're part of our multidisciplinary limb preservation program. We call it our LAMP, LAMP, Limb Amputation Prevention Program. They're always just a phone call away. In fact, one of them was in clinic with me today. One comes every month, and we do a multidisciplinary clinic right in my clinic. So the patients see me, they see vascular surgery, all in one fell swoop. So we find that we can get our revascularizations scheduled much faster. We can get them done. It's the old, as David Armstrong calls it, toe, flow, and go. You see the wound, you get the circulation fixed, and you get the patient going towards healing. Yeah, I mean, another caveat with the ABIs and everything is dialysis patients. You can't really hang your hat 100% on it, but I'm still a fan of TCOMs, the transcutaneous oximetry measurements that we used to do a lot to determine if a patient would benefit from hyperbarics. I think there's still a lot of knowledge to be gained from TCOMs. The TCOM is a little more time and labor intense, and you have to have a technologist who's pretty skilled at doing the test. But there's still a lot of information that can be gleaned from a non-invasive study. And of course, I do venous reflux studies almost every day to try and see if there's something that my vascular surgery colleagues can attempt to ablate or use a sclerosing agent.
That's wonderful information. I think it's been an incredible discussion. Obviously, we've all enjoyed it. We're going to have Dr. Mary Beth Hanley back on the show if she'll be kind enough to accept our invitation in the future.
Anytime, I'd be happy to.
Thank you very much. One of the things that I'm fond of doing is leaving the last question to our fearless leader, Dr. Paul Reeves. Paul, do you have one final question for Dr. Hanley?
I just want to be clear I understood what she said because, I might have a neighbor I could go talk to tonight after the show. And that is, are you making it clear that the Mountain Dew Little Debbie cake thing is a bad combination for breakfast? No names. I will not mention his name right across the street from me. Just wanted to verify.
Yeah. I cannot in good faith endorse that nutrition status. Yeah.
Neither one, right? It's a bad combo, but just one alone, still bad?
Absolutely. Yeah.
Okay.
Yeah. Cannot recommend either.
All right. And the greatest piece of news that, I learned tonight, in all seriousness, I've heard this before, but it came through even more clearly tonight. Basically, get off your backside and go for a walk. Even if it's to the kitchen and back or the bathroom and back, do something. But the sedentary life is really bad when you have this.
Absolutely. Yeah, it's so true. Like Dr. Attinger says, when you're not walking, you're dying.
That's a very, we should post that everywhere.
Sitting is the new smoking.
Yeah,
absolutely. I love it. I love it.
Well, I'll ask one last question because as somebody who made it just beyond a Cub Scout to what was called a Weeblo and never quite made it to a Boy Scout, is it true, Mary Beth, that you have raised 2 Eagle Scouts?
I have, and that is something I'm incredibly proud of. My middle son and my youngest son are both Eagle Scouts. They started as Cub Scouts and they stayed with it all into high school and both completed their Eagle Scout project, and I got to pin them. And really the reason they did it was because of my husband. My husband was very active in scouting with them. He was one of the troop leaders. He went on all the camp outs, bless his heart. I don't know how he did it. But it's an achievement that I'm very proud of, that they are very proud of, and it's something that they can take with them their entire lives.
Yeah, you should be. That's quite an achievement. Paul, were you an Eagle Scout?
I actually made the same level you did. I got into the Weeblos and just kind of flamed out.
Uh-huh. Well,
I under my excuse is I had bad leadership, which is actually true. I could have fought through it, but I thought this is just nonsensical. I'm out.
Leadership. I was just a born loser.
Look at all you.
We're not all destined for greatness. That's all I can say.
You got to that whole tire rope thing. And I thought, okay, I'm out. That's not one of my strengths.
It's a wonderful, wonderful discussion. I think with that, Paul, I'll ask you to sign us out and say goodnight, and we look forward to the next one.
All right, another terrific show you've been listening to and watching if you're on YouTube. Our LymphCast show, episode 66. And by the way, tonight's show was brought to you by Vita Support MD. Dr. Johnny Chubak is the founder and owner of that company. They make Vein Formula 1000, Lymphatic Formula 1000, and you can find them vitasupportmd.com. Don't forget, you can buy us a coffee to help financially support the show. Just go to buymeacoffee.com/LymphCast, and we thank you in advance for your contribution. We also want to invite you to check out our website early and often. We're on every podcast platform under the sun, and as I mentioned, we're on YouTube. But our website, lymphcastnetwork.com. If you have a question for anybody on the panel, the email address is hello@lymphcastnetwork.com. And before I go around the room and thank the regular panel folks, Dr. Chubak, can you thank our special guest tonight?
Yes, Dr. Mary Beth Hanley, thank you so much, not only for being on the show tonight, but for your incredible contribution to healthcare and to wound care. And I speak for all of us, I'm sure, when I say I am so glad that your friend called and insisted that you get back into the medical field and do that family practice residency. And just think how one phone call can change not only one life, but all the lives you touched as a result of her caring about you and motivating you. So whoever that doctor is, we thank her tonight for all that she's done. And
she's still a dear friend.
Thanks for being on the show.
Thank you for having me. It was wonderful.
All right, man, great job. Let's go out to California. Dr. Emily Eicher, thank you for everything, ma'am, and we'll see you next time.
Thank you to all of you, and a special thank you to Dr. Mary. And now you know this is your path. This was meant to be for you. And thank you for being such a champion and doing such a great work.
Thank you, Doc.
All right, and headed back toward the east a little bit in Arizona, Dr. Monica Glavitsky. Thank you for everything, and we'll see you next time as well.
Thank you for having me, and thank you, Dr. Hanley, to sharing all this that precious experience that you have in wound care and hyperbaric treatment. And I'm looking forward to have you again on the program.
Thank you so much.
Thank you.
Thank you. And the gentleman, as I mentioned, he is the founder and owner of Vita Support MD. He's also the founder and owner of this show from New Jersey. Now we've gone all the way east. Physician surgeon, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Still not an Eagle Scout, Paul. No matter what.
Neither am I. That could be. Why don't we get together tomorrow, see if we can find a good leader and just go for it. Ever too woke. Or
if we needed to start a fire, we would need a book of matches, a lighter, kerosene, just a cake.
That's right. The old joke, can you start a fire with two sticks? Yes, as long as one of them is a match. So that's my skill level. Yours too, I'm guessing, right?
Stick to your day job. Calm
That's right.
Paul.
You got that right. Once again, our LymphCast show, episode 66. Thank you for being here. We'll see you next time for LymphCast 67. Have a great night.